Good morning. We start the Dr. Shobit will join us very soon, and we start this symposium. Actually, the symposium was devised by Dr. Vishali, but unfortunately, she has not come for this meeting for personal reasons. And we start this on macula, and the first talk is on macula in neonate by Anand Vinekar.
Thank you, sir, and thank you for the opportunity. Okay, so I'm going to sort of run through some sort of clinical case way on how to discern some of the important things in a neonatal macula and some of the recent advances in imaging this. First of all, it's a fairly common problem. We did a universal screening study over 1,000 babies and found that about 4.6%, that's 46 per 1,000, had abnormalities. And 19 per 1,000 or 1.9% had abnormalities that required treatment. Now these are, remember, term healthy babies, and they are being imaged in the first 72 hours of life. So it is probably more common than we think. And my slides are not moving. Okay. Right. Now let's look at a more at-risk population, the preterm babies. So while screening them for ROP, we find that there are other macular problems as well. We know the most common ones are hemorrhages, and white-centered hemorrhages and hemorrhages in per se have some issues, and these are the ones that direct us to more sinister problems that they may have systemically. As you can see, these preterm babies can also have retinoblastomas, they can have cherry red spots, and they can have retinal vasculitis, all of that happening in the macula. So imaging then becomes an important aspect, and let's see the kind of imaging tools that we have at our display. So this is a regular case of 1,500 grams, 32 weeks, preterm baby coming for ROP screening. I'm not sure how much detail you can see the vessels with, but it's tortuous, dilated, there's capillary non-perfusion, there's some sort of hemorrhage. So this is a classical case of aggressive posterior ROP. But if you look at the baby as a whole and you look at the systemic parameters, you find that there's blood platelet count of 23,000. So clearly this is thrombocytopenia. This was the index case where we went in actually to do treatment, and then the neonatologist said, hang on, I need to transfuse some platelets. And about 72 hours after 3 transfusions and bringing the count to about 1.1 lakh, the APROP spontaneously regressed. We thought that could be a coincidence, so that actually led to a retrospective and then eventually a prospective study where we found now that thrombocytopenia of less than 1 lakh is an independent risk factor. And platelets themselves have pro-angiogenic factors and anti-angiogenic factors, and given at the right time and probably the right volume, they can reverse certain findings. And this is that study which now today all of us look for low platelets. So when there are smaller things that we need to look for while we are looking at the macula, because especially in a neonate, since this is my topic, the vessels itself are not very well developed, and the classical choroidal flush or the look of the choroidal vessels itself are not seen. So just inside the macula or outside, many times we see these creamy placoidal lesions. This actually prompted us to believe that this could be vasculitis, and we investigated the baby thoroughly. When all the bacterial screens came negative, we found that the child actually has fungal pyuria. And so this was a candidal abscess sitting around both kidneys and giving a lot of those hyphae into the urine. The child probably survived because of, because of an early detection, because of a retinal finding. Again, these are routine screening. Our babies who come to you for many other things, and then you look carefully and then you find lesions. So whenever you see one lesion, look for multiple. And this was a case of tuberous sclerosis. And of course, it comes with other systemic comorbidities like seizures, like heart disease, and none of that was known to either the pediatrician or the parents. And just because we looked at the macula and we sent back the baby to the pediatrician, that's when these things get picked up. So it becomes a sort of responsibility, and of course you can pick up these lesions better on angiogram and OCT. And they have different configurations as well. So what about microstructure? So I think we've learned a lot after handheld OCT has come. Before that, all of us have tried all kinds of maneuvers to image these babies. But from what I want you to see in the next few slides is where these two blue arrows are going to come towards each other. So these are the photoreceptor layers, and we are not born with them. We are not born with this layer or the ellipsoid zone if we are born preterm. So at 38 weeks, 42 weeks, 46 weeks, 47 and 48. You saw that the two layers come from out inwards. So this is a centripetal action. So we actually develop this layer if we are term or maybe 1 or 2 months after term. And the role that these layers have if they are delayed to vision is something that we've been interested in, and we've looked at that in a few of our publications. But look at this clinically normal looking macula, and then you find what is now being defined as an entity called macular edema of prematurity. And it went away. It went away in about 6 to 8 weeks, but when we followed up these babies, we found that they had slightly more hyperopia, just like the CSCR, and they actually had disadvantaged vision in the first 3 to 6 months, which caught up at the end of the first year, of course, after a whole lot of vision stimulation. So even normal looking macula, when you image them and you have so-called subclinical transient foveal edema, these seem to be playing a role in vision. So we looked further into all the other layers and which of these prognosticated with vision, and we found that persistence of the inner retina, a deeper, slower foveal dip, and absence or a shorter height of a foveal tent, all these correlated with poorer vision, even when they had normal maculas. And then this is that paper which looked at the extended spectrum of OCT in pediatric population. So yes, there's OCT, but can we look even deeper? So OCT angiography, or OCTA, has now at least got 2,000 publications, maybe in adults. But in peds, this was probably our first paper here, where we looked at aggressive posterior ROP, and we were looking at these vessels not only on the superficial area, but for the first time, seeing what it looked like in its deeper extensions. And what's important is we were able to selectively target these vessels, these vascular fronts, with laser, and then show that they disappeared even on the deeper penetration. So this then led to a slightly expanded study. We looked at older babies who are between age 5 and 10, who were preterm historically, and we found that even when they had type 1 or even type 2 ROP, so type 2 ROP is ROP that spontaneously regresses, that does not need treatment, and they have normal looking fovea and better than 6/9 vision, even then their foveal avascular zones look abnormal, and their perifoveal deep capillary plexus have broken filiform appearances. So this is what the take-home was. A normal-looking FAS was seen in the controls only, that is, babies who did not have ROP. But those who had ROP, even transient ROP, had abnormal foveal avascular zones. So some of the innovations that have come in imaging the macula, of course, is I don't have any financial interest in this, but we have been the PI for validating this Indian ROP camera. And this is the RetCam shuttle, which gives you a rectangular image. And with the new NEO, you're able to get a full circle. So an additional 2 arcs above, and it is now an FDA and CE approved product. It gives about 120-degree field. It's portable. It's about 1/8 the cost of the RetCam, and it's being used extensively in the rural outreach areas. It has 2 international patents. It has a liquid lens and so on. But going forward is, after you take all these images, if you're able to process them, and that we've been interested in. So we've been trying to segment these vessels and quantify them using some MATLAB software. We're able to predict the severity of the disease, and eventually we want artificial intelligence to detect whether the image has disease that requires follow-up or disease that requires treatment. So part of that work has been some sort of software which we call RetiView that enhances normal features and gives you exactly where the blood vessels end. In other words, clinically, this was a zone 2, but a zone 1 disease, I'm sorry. But when you process it, you see that there are smaller capillaries that go on to zone 2. So if you reclassify an ROP from zone 1 to zone 2, it means a lot for the baby in terms of management, prognosis, and the overall outcome. And it is only because you are able to heighten these features using certain vascular software features. So these are some of the new things that are happening in the way we're looking at the macula of a neonate. Thank you.
After each talk, we'll have a few questions from the audience and also from the, okay, yeah.
Nice talk, Anand. I just want to know, when you use OCT angiography, which is still technology that needs validation, when you're moving a child from type what would conventionally be zone 1
right.
to zone 2 based on this little
right.
image, are you basing your treatment henceforth, would you say, on OCT angiographic based staging or your clinical staging?
No. So the two things. One is the Octa one did not have that zone 1, zone 2. That picture which you saw on the right was actually a software that completely analyzed the vessels using what we call the vesselness protocol. So that was not Octa. That one we noticed that clinically the blood vessels ended in zone 1, but after enhancing it, we found that the smaller capillaries extended to zone 2. But these were all in retrospect. We had treated that baby as zone 1 only. So I would not go to the point to say that it has changed our management, but so much to say that there are better ways of looking at what we are looking at traditionally. The Octa, on the other hand, is giving us, I would say at this point of time, a better understanding of fovealization. And how it would impact vision and the older child, that's something that we need to look at.
I have one or two questions. I mean, not directly related to your talk, from the pediatric point of view. Now, two questions. One is, we, in our younger days, we used to label what is known as congenital amblyopia. And we used to say this is because of a foveal hemorrhage at the time of birth. Now, have you done OCT and Octa in these sort of patients?
Right.
And the second question is that in eyes with amblyopia, where we give this occlusion treatment, etc., in the pediatric age group, do you have any, data to show there is any change in the macula over time with the improvement of vision, etc.?
Yes, so thank you. Actually, two important questions. So that paper that I put out for the expanded spectrum, 1/3 of our patients today are being referred by our pediatric ophthalmology colleagues for children who they would otherwise have labeled amblyopia, or at least to say that they did not improve after this conventional therapy of glasses, contact lenses, and compliant patching. And we have found that in fact, all the cases that I mentioned there, the total 932, all of them had changes in the OCT. At that time, we had not done the Octa. In the OCT, where you could actually look at thinner neurosensory retinas, abnormalities in the ellipsoid zone, differences in the foveal tent. Now, not all of these change with therapy. We have been, our clinic there also has a very good vision stimulation center where we use software-based vision stimulation. There has been visual improvement, but we have not been able to document that as a structural improvement on the OCT yet. Maybe it's not sensitive, maybe it doesn't change, but functionally it seems to improve. But structurally, we are able to discern a whole lot of amblyopes and reclassify them as structurally abnormal foveas.
Any questions? Pramod, you want to say? No, that's any more questions to Dr. Anand? I mean, very interesting talk. And I'm probably the only person in our country who has worked on this particular subject, and he's been working steadfast. That's very important for youngsters. You must be focused, work on something, work on continuously, you get results. I mean, that's I think where many of you lack. Thank you, Anand. I mean,
yeah, the next talk will be Dr. Shobit. He'll be talking about exactly opposite now, macula in aged patients. Pediatric geriatric totally.
Yeah. Good morning, everybody. Aging affects all parts of the body and the mind. And so the aging macula classically has a lot of changes, drusen and ischemia being one of them. So in the eye, the main site of accumulation of these deposits is the Bruch's membrane, as we all know. And with age, the Bruch membrane thickens, its composition changes, and it decreases the diffusional capacity, showing a 95% reduction in dextran diffusion rate between a 90-year-old and a 9-year-old in a Bruch's membrane. You see this histo, and this is hard drusen, deposits from underneath the RP monorail within the inner collagenous layer of the Bruch's membrane, not so dangerous. The classical soft drusen, significant displacement and flattened RP from the choriocapillaris is observed. Somehow the mind still works on the old classification we learned rather than the OCT classifications of drusenite deposits which have come. Hard drusen are observed in both aging retina and AMD patients. Hard drusen do not significantly increase the risk of developing AMD, as only 2.9% of patients over a 14-year period ever developed geographic atrophy or CNV according to the Copenhagen City Eye Study Group 2005. And there are higher rates of geographic atrophy and CNV in patients with soft drusen. So the difference in soft drusen are found exclusively within the macula, while hard drusen can be in the mid-periphery and the periphery. They can be with basal laminar deposits or basal linear deposits. And the not so, we see a lot of reticular deposits in the fundus, which we label as reticular, which we see in the periphery also. And they are normally harmless and need to be recognized. So you look at this RPE, and this is in a young patient. And while this is in a patient with age-related macular degeneration, this is in a normal patient, an age. Look at the pleomorphism, the size of the cells, and the atypical look leading to various kind of changes. So lipid hemostasis, there is higher accumulation of esterified cholesterol occurs in macular book membranes than in periphery. That is why the macula, the watershed zone, is so prone to diseases. Something which we use in our clinical application, the lipofuscin granules, which we use in autofluorescence now, and that there are changes in this with age, as I'll demonstrate in the autofluorescence model. It's here. I think choroidal thickness as well as choriocapillaris density and diameter decrease as a function of age in healthy human eyes, but are significantly reduced in AMD eyes near regions with basal laminar deposit, geographic atrophy, and disciform scar. So this is just a schematic presentation of the pathophysiology of the changes and the neovascular process which can happen with soft drusen and basal laminar deposits. So we are all aware of these changes and the expression of VEGF and the treatments which we do for it, leading to these devastating issues and which require anti-VEGF therapy. So as we recognize more and more significant aging changes, and in Asian eyes, we all know, as we are recognizing more in India, we are seeing atypical changes also. Along with CNV, we are seeing a high percentage of cases of polyps and branching vascular networks, which is one of the call for doing more and more ICG angiography in our patients. Nearly 55 to 60% cases in our observational studies, which we will try to, it's high time that we did some studies related to the incidence, actual incidence, multicentric trials as to the number of cases we are labeling as CNV, which could be PCV. So this is autofluorescence. This is the autofluorescence images. That's the pseudo color images on a Heidelberg system, and you see the hypoautofluorescence. What is significant is the hyper-autofluorescence which surrounds this area. This indicates activity in the lesion, and these are the patients which will progress in their visual loss. Just now this patient maintains 624 vision because the foveal area is free of any dead area, as you see in the hypoautofluorescent area. And now as these hyperactive cells, which are fluorescent fringe, becomes diseased and dead, visual loss is bound to progress. As of date, we have nothing much to offer these patients. In central areolar geographic type atrophy, it's not that active, you just see the lesions, and this patient can maintain this kind of vision for years, unlike the last patient. Some deposits without much change and good visual acuity. Again, Here the fovea is relatively better, but there is some activity as you see in the fringe, and this prognosticates the chances of further visual loss in this patient. Thank you very much. Welcome you all to the Vitreoretinal Society India meeting in Lucknow this year.
Any questions? Any questions, comments? I had a, I mean, not a question, a comment on the question. The thing is, basically, as we age, we know that one is the choroidal thickness decreases with age. I mean, it's been documented that at every 10 years of our age, there is a decrease in the choroidal thickness. And is there any decrease in the central foveal thickness as we age? That is central macular thickness. Is there any decrease in the thickness, the central macula, as we age?
Not
in a normal macula.
In a normal macula, it's not, but in disease there is. Well, you would label it as a degenerating macula if it decreases in central macular thickness.
Because
but there won't be necessarily visual loss.
Because why I'm asking you this question is this is very relevant because see in many patients with not a diseased macula, but many elderly patients who have some element of cataract, and sometimes you wonder whether especially when the quantum of cataract is not very significant and there is a loss of vision, and we do an OCT, and sometimes we come across a central macular thickness of 260, 270, etc., which is less than normal. So whether this is just an age related, because these patients do well after surgery.
Yeah, they recover. That's why it's not exactly a marker for prognosis. Many of these patients which macula look dull, there's no foveal reflex, and you do a cataract surgery. I think OCT has become part of a pre-op workup in most centers, of pre-op cataract workup today in most centers.
Are there any predictors which are there, like we have clinically what we have been knowing on OCT, which is going to predict that these are the cases we would require sort of a very, very careful follow-up? Are there an OCT predictor for conversion?
I would say more than OCT, autofluorescence, according to me, is a more important test today for the aging macula rather than OCT. Fundus autofluorescence is more of a metabolic test, and that's more important. That is altered. I think that's more relevant to monitoring therapy when you're doing anti-VEGF therapy, especially in diabetic macular edema and other conditions.
Actually, yesterday we were discussing what you are talking about, that we have a evening symposium, particularly when autofluorescence you are showing the dark areas, but in microperimetry shows some activity there. So probably though we talk that entire area is dead, but probably there is some minimal activity is there, and probably we were discussing, like yesterday Dr. Giridhar only asked like about whether chances of regeneration of RP, and we were discussing probably these are few areas. We do not know it, no answer to this as of now.
Just to address Dr. Mangat's question, I think a few years back when Dr. Rosenfeld came and gave the talk on subclinical CNVM,
yes,
that is what is now understood as the key. Suddenly you find drusense, then you find the patient suddenly having a CNVM. There has to be an intermediate stage. So now intermediate and subclinical CNVM is understood, but obviously it requires higher level OCT, and the swept source OCT, which I think Shankarnetra has Flexelite, that is showing up many things. You need to understand that there are these particular lesions there, and when you do OCT angiography, you understand it even better. You see it growing in that sub-RP space and not exuding. So it is subclinical, non-exudative AMB now.
Yeah, Anand, I would just like to raise a question that we are over-diagnosing these cases with that. We are seeing atrophic maculas, and we see a CNV sitting underneath on these new modalities, which Dr. Spade also showed in his presentation. Are we going to treat these? Yeah. That's the issue. Should we be? Yeah, it doesn't really make sense to treat.
No,
gives us an indication as to what may happen in the next
Yeah,
few
probably we do not have answer because that's too early to say, because we are just trying to identify, and that's what we are debating now. It's a subclinical. Only OCTA is showing, particularly same thing with your MacTail also. And we do not know whether to treat or not to treat. Probably with time will answer that one, probably these early stages. And logically looking at it, if you treat at this stage, probably you may preserve vision long term. But we know again, your anti-VEGF again cause atrophy, further thinning. Yeah, we do not know. Yeah.
I think the real importance of subclinical changes is when you're looking at the other eye of a patient with one eye having a devastating disease like PCV, and you see subclinical changes in the other eye, that is the patient who requires a real close follow-up in our clinical experience.
So I think basically the take-home messages, I think when you have a discussion, it creates some confusion also. So basically I think the take-home message from this last part of the discussion is basically to identify patients with subclinical macular disease who require careful follow-up. And what Philip Rosenfield actually described was the presence of silent choroidal neovascular membrane in eyes is soft drusen. So the patients with soft drusen have got a higher chance of wet AMD, and he has described silent choroidal neovascularization asymptomatic in such patients. Therefore, these are patients who need very careful follow-up. And basically, as you're all aware, injecting the drug doesn't destroy the neovascular membrane. So even if you inject a drug and repeat the octa, you may again continue to see some mature networks, and therefore that doesn't really kill the disease. Therefore, there is no purpose in treating these patients at that stage, but these are patients who need very careful and regular follow-up. So, can we move to the...
Yeah, I think so. Yeah, I will finish.
Sir, can you have your keynote address, sir? Your keynote address? It's not correct to keep the invited speaker waiting till the end. And Dr. Lalit is here. Dr. Takeshi Iwata will talk on novel genes and molecular mechanisms for retinal disease. So you can also introduce yourself.
Okay. Well, thank you very much for the invitation. I'd like to thank Professor Natarajan and the program committee. Since I did not know whether which session I will be invited to, and I just noticed yesterday, so I just modified the slides so that it will fit mostly into this sessions. So I'm not an ophthalmologist. I am a molecular biologist, molecular geneticist, I actually say, from the Tokyo Medical Center, which is a national hospital organization, which is a Japanese hospital under the Ministry of Health of Japan. So we do a lot of basic research. We collaborate with many clinicians and try to identify the disease-causing genes and mutations. So today I'd like to focus on the retina, and of course this session is on the macula, so I will be talking about the macular. So macula is a very unique tissue in the eye, and this structure is very unique. This structure only exists in higher primates and also very few type of birds. And so that's why the experimental animals like rats, mice, dogs, cats, pigs, cows do not have a macular. Only higher primate with a high resolution vision have a macular. So what kind of risk factors is involved for this macular diseases? And one factor is, of course, genetic factors and also environmental factors. Environmental factors contains like blue light, obesity, smoking. These kind of risk factors is also environmental factors, but also there will be genetic factors. It is a little bit difficult to measure the environmental factors, so we usually try to start with the genetic factors. So that's what many people have done for age-related macular degeneration, as we heard from the previous speaker. So this is called the Manhattan plot. You see chromosome 1 to chromosome 22, and it is showing that the association of a DNA which part of the chromosome of DNA sequence is actually associated with AMD. This is a comparison of a control, 30,000 people control versus the 30,000 AMD patients, and it's called the genome-wide association study, and this is called the Manhattan plot. It looks like. So as the lines goes upper, it means that the p-value 10 to the minus over 10 to the minus 8 is being considered as an association. So among these genes, you can see on the chromosome 10, there is a one place that is highly associated with AMD. The p-value is 4 times 10 to the minus 353. So this is one of the places that we have to study. So that's what we did for this. Here, when we zoom into this chromosome 10 area DNA sequence, there is 3 genes that are highly associated with the onset of AMD. So this line, red line, is exactly what the sequence is. So we focus on this part of the regions to see how this can lead to age-related macular degeneration. When you sequence this part and compare with the controls, you would see that this red part of these 2 genes is changed in the AMD patients. So what does that mean? So this is a experimental procedure that we do. We take the normal patient's DNA sequence, and then we change to AMD patient's DNA sequence and measure the promoter activity. Promoter activity is the amount of expression of RNAs from this DNA sequences. So number 1 is the control AMD, control person, and if you replace the AMD sequence, you can see that the transcription is increased significantly. So it means that, I'll go back 1 slide. It means that if you have a AMD sequence here, it means that the HTRA1 gene right behind this sequence, the transcription will go up. So this is what is happening. This is a normal DNA sequence, and then usually you will have a suppressor protein that is binding to these regions to suppress the HTRA1. But if you have an AMD sequence, one of the suppressor is lost and replaced by an activator protein. And this increases the transcription of HTRA1, means more RNA, more proteins. So this is a cell that's called the iPS cell. This is a stem cell that you can make from each individuals, and you can measure the amount of HTRA1, whether AMD people actually have a higher RNA levels. So this is the AMD patient, this is the normal patient, this is the glaucoma patient, and this is the AMD patient. As you can see, if you have an AMD, HTRA1 level is higher in these people. Where is HTRA1 expressed in the eye? So this is immunostaining, and you can, if you can focus on the green part, this is where the HTRA1 is expressed, and this is mainly in the photoreceptors. So what we did is that, okay, in the humans, HTRA1 is highly upregulated. So if you make a mice, a transgenic mice that overexpress HTRA1, would you get a phenotype like human AMD? So exactly what we did is like that. And we use a special camera for mice, and then we do the fluorescent angiogram and ICG to see that, yes, there is a capillary coming out through the Brook membranes into the retina. And here we can see that, yes, there is a CNB coming out. Although the mice does not have a macular, but you can replicate without the macular that the CNB can be replicated by just overexpressing HTRA1. So now we're currently collaborating with the pharmaceutical companies to suppress HTRA1. If it's high from the stem cell level, if you suppress with drugs, you will probably suppress the onset of age-related macular degeneration. So now I'd like to move on to the more extensive genetic factor diseases. And these genetic factors can be like macular dystrophies, Stargardt diseases that are caused by a single mutation in the gene. So we have many these inherited retinal diseases, and there's like about 36 inherited retinal diseases, including macular dystrophies and Stargardt diseases. These we call the IRD, inherited retinal diseases, is caused by almost 260 genes. It has been, first gene has been cloned in 1988, and now we have about over 260 genes. And as we analyze more population around the world, I think we will be about 10 times more. We will have more disease go. So I'm currently the head of the Japanese consortium, started in 2011 with 30 ophthalmology departments in Japan, and we are currently trying to solve this 36 labor congenital amaurosis, retinitis pigmentosa, Usher syndrome, Stargardt, macular dystrophies, and so on and so on, retinoschisis, Best disease, so on and so on, and try to find. So we are currently in the center, and there's clinicians sending out phenotype information and saliva or blood sample to us. We do the sequencing and transcriptome, proteomes, and gene editing to create a mouse model and then primate models. We are also in association with many foundations and societies in Japan, and developed a registration system, genotype-phenotype database, that the blue part, the clinician will input their OCTs and all this image fundus photos, images you can upload into this system, and the genetics will put all the genetic information into this part. So we have tried to increase the quality of this phenotype by asking this specialist, a disease leader, as a disease leader, to monitor the incoming data from all these universities of different diseases, if this is really that diseases. So this quality check is very important for this to run the consortium. And once it's cleared, and it goes through the whole exome sequence, whole genome sequence to do the whole thing. So we have collected about 1,300 pedigrees, 2,000 samples, and then we have sequenced the entire gene, 20,000 genes of all the patients that we had. So this is the whole exome sequence. And if it's a recessive family, we will sequence parents, affecteds, and even a normal brothers or sisters to filter the cause. Sorry. Okay. Oh, time's up? Okay. Okay. Okay, so in 2001, when we started the consortium, the detection rate of these mutations were 17%. But with this new technology of next generation sequence, the computing, everything, we have now increased just in 7 years to 53%. The Moorfield's detection rate is about 65% currently, which has about 30 years of experience. So I think with this new technologies, any nations can quickly catch up to the most. So we are currently identifying the genes and try to find the mechanism by using a protein work, the iPS cells, knock-in mice models, and try to find a drug. So I would just show you two macular diseases. One is called Occult macular dystrophy. This is identified by Yozo Miyake, the director of our institute. If you do a fundus photo, it's normal. The fluorescence angiogram is normal. And if you do a full ERG, it's normal. But if you do a focal ERG, you can see that the fovea cone is totally lost. So we took 3 years to clone the genes, and it's called RP1L1. We now have 50 pedigrees of this, and confirming that this is the real genes. And we're trying to make a monkey model of this. This is another gene called LRRTM, leucine-rich repeat transmembrane 4 proteins. This protein is actually expressed in bipolar cells. Bipolar cells, it's a synapsis protein, but if it has a mutation in this proteins, the photoreceptor degenerate. And as you can see, this autosomal dominant family, you can see that the huge hole in the macular regions. So it's a very special gene, and also it's a very new phenotype that we're seeing that the bipolar cell dysfunction actually degenerates the photoreceptor, and it's specific to the photoreceptors. And we have been studying other genes. This is a new gene for Leber congenital amaurosis, and also there's a new gene for RP and rod cone dystrophies. So all these new genes is coming up, and I think if we go into more of the Asian population, we will explore more new genes that has not been found in the Caucasian population. So I will end with this slide that we have also started a global genetic consortium based on the experience of the Japanese consortium. Now 30 universities, countries are on board, and we will have this GEGC consortium immediately after this session at Hall H. So if you're interested in genetics, please come to us, and this is the website. So thank you very much for your attention.
I think any questions we have? Quite an exciting field now. I think we're looking at his presentation like future we are looking at something.
Thank you for the presentation,
Thank you.
sir. I was curious as to what's your thoughts on using CRISPR-Cas for genomic editing of for the inherited retinal dystrophy?
Yes.
And which one of those do you think is a good target?
So for gene editing, it's still is ongoing. I think it's a research, and then the recombination rate is about 5%, and you can improve this by up to maybe 10%. But I think still you can recombinate safely about 10%, but also you might have a off-target which will replace and damage other genes, and it's you have to be very careful with this. I don't think there is a safe technology for it. We should wait for another technology to come.
You did mention that you're using therapies. So which ones, what therapies are we developing? If you could
Yes,
elaborate
so
on that.
basically we're testing through this metabolism changes, especially we will find a lot of mutation that will enhance the interaction of protein with usually not wild type. Only the mutant will bind to a specific proteins. So in that case, if you have a drug that will prevent from binding, I think it's a very, and I do have another slides for those, but yes, so drug development is of course good. And also for the recessive families, putting the normal cDNA into it should help significantly. But for others, especially for dominant families, I think gene editing will be the future, I think so, yeah. Thank you.
Thank you, sir.
Thank you.
Yeah, the next talk, we have Dr. Anand. He'll be talking about macula in myopia.
So good morning, everybody. We talk on macula in myopia. So myopia basically refers to a condition in which individuals have an axial length exceeding a certain threshold. It's typically about 25.5 or 26.5. That's been accepted. A corresponding refractive error of about -5 diopters, and which is accompanied by very characteristic pathological changes that most of us are familiar with. It's a major cause of irreversible vision loss. It's been looked all through the world. Globally, it's about 4th to 9th most frequent cause of blindness in the world. Untreated has a poor visual outcome. Associated CNV is the leading cause of vision impairment in patients younger than 50 years. It's a major public health concern in many parts of the world, especially in Asia and the far east especially. There's wide variation in prevalence from 0.2% in Egypt to 8% in Japan and the Orient. And that's where it's a major issue. In fact, work being done by Tian Wong suggests that in time, by 2050, myopic chorioretinal degeneration, myopic pathology will be the leading cause of irreversible blindness.
Prevalence of myopia has increased markedly over the past few decades. 10 to 20% of high school students have a high myopia of 6 diopters and more. Up to 40% of subjects with high myopia of 6 diopters and more had myopic maculopathy, and various changes which we'll look at. Pathogenesis is basically because of the progressive and excessive elongation of the eyeball. Collagen fibers in myopic sclera are pathologically abnormal. Smaller fibers have lesser cross-linking those in emmetropic fibers. So Avila has put out this erstwhile myopic maculopathy classification, which is generally followed all around. A number of pathological features which we look at. Tessellation is the first thing that we obviously see. Is defined as a condition in which the choroidal vessels can be seen through the retina owing to obviously reduced pigmentation or hyperplasia of the RPE. Myopic maculopathy, it's been noted, tends to progress more quickly after the stage of tessellation is noticed. 13.4% of eyes with a tessellated fundus show a progression of myopic maculopathy over a period of 12 years as noted by Silva. Lacquer cracks are ruptures in Bruch's membrane. In eyes with myopic CNVA, their incidence can be upwards of 75%. Lines are fine, irregular in cadabra, yellowish white, horizontally oriented or crisscross. And almost 70% show, once these are seen, they show progression of maculopathy. Incidence of progression to a CNVM was higher in eyes with lacquer cracks or patchy atrophy than just a pure tessellated fundus. So once you see that, you know that this patient needs a closer follow-up. So this is a blow-up of that. Fuchs spots, elevated pigmented circular lesions are caused by fibrovascular tissue ingrowths and are often considered late-stage myopic CNVM. Fuchs believed this dark macular spot to be related to proliferation of retinal pigment epithelium, and angiography showed neovascularization extending into the choroid, into the subepithelial space has been identified as preceding this. Gass also noted that an acute hemorrhagic detachment in this area ensures this development of new vessels, and subsequently this hemorrhage organizes and may combine with that proliferation of RP to result in the dark Fuchs spot, as you can see. Atrophic patches can be focal, patchy or diffuse, can be irregular or in protein in shape, yellowish white in color. Variable amount of pigment clumping may exist within these. When it extends to the fovea, obviously vision will be deleteriously affected. Can be diffuse. About half of eyes with diffuse atrophy and 70% with patchy atrophy also show progression. So posterior staphloma is basically outward protrusion of all layers of the posterior wall of the eye. Hallmark of pathological myopia, presents early in life, increases gradually with age. Prevalence obviously increases with axial length and myopic refraction. Depth and size of this posterior staphloma can be documented with stereo examination, B scan and OCT. 10 different types of staphloma has been described by Curtin, types 1 to 5 the basic staphylomas and 6 to 10 the compound staphylomas. Myopic discs are typically tilted and oblique. The nasal sign frequently has a raised edge which has been called supertraction, and the temporal side is often surrounded by a concentric area of depigmentation, the myopic conus or temporal crescent. Myopic CNVMs, the most deleterious aspect of pathologic myopia, estimates in about 5 to 10% with high myopia. 62%, as I mentioned, one of the leading causes of CNVMs in the 50 years and young. Obviously, poor poor natural history without treatment. Prognosis worsens with age, increasing age, and 80% have acuity less than or equal to 660 in 5 years once it onsets. Untreated leads to choroidal atrophy. So what happens basically is excessive axial globe elongation, subsequent mechanical stretching, thinning of the choroid and the RP, Bruch's breaks, RP atrophy, myopic maculopathy, resultant choroidal ischemia, and finally the CNV formation. Examples of scarred and active CNVA. Here FFA probably has a greater role to play than in AMD CNVM, because AMD is fairly obvious, but to distinguish between that fuzzy little fuzz from a Fuchs spot, spontaneous bleed, and a myopic CNVM, I think fluorescein is very needed. Dome-shaped maculopathy is something that's been recognized probably in the last 5 to 10 years, little more. There's because of the irregular contour of the posterior wall, as you can see here, the sclera is indented up, and the macula and the RP is stretched, and you can have degeneration and in fact serous fluid also coming, which does not respond to anti-VEGF treatment. Enhanced depth OC has helped us look at the choroid better, and there are many studies which show the thinned out choroid. In fact, it's absolutely wafer thin. Treatment options, these were the archaic ones earlier. Current options, anti-VEGF treatment is the standard of care. ranibizumab, aflibercept have been accepted. Bevacizumab also works quite effectively. PDT, which was the erstwhile treatment earlier, we'll come to that. We'll see the web report. Well, there are a number of studies. Wang and Chen put a meta-analysis and looked at a number of about 100 plus studies and averred that, of course, anti-VEGF therapy is the way, is one of the top, is the way to go with myopic CNVM. Radiance was one of the studies. PDT, as I mentioned, the WIP report showed favorable outcomes initially, but at 2 years, the beneficial effect was lost completely because age-related atrophy also started setting in. So current evidence confirms that first-line therapy is anti-VEGF intravitreal injections. Ranibizumab with the Brilliance and Brilliance showed that. Aflibercept with the mirror study showed that, and a host of other studies with bevacizumab showed that. The dosing method could be either 1 plus PRN or loading dose. Combination treatment is a viable option, especially refractory cases. And if it's extrafoveal, one might even, if it's a small one, might even consider laser. So this is a case where it is treated with Lucentis earlier, Accentrix, and you can see the regression. The fellow eye had undergone PDT 5 years earlier, and you can see the surrounding atrophy, which is why PDT is not such a great option. Now, a very interesting study, a basic science study by An et al. On association between choroidal morphology and anti-VEGF treatment outcome in myopic CNVMs. They used EDI OCT to look at the choroidal thickness and at different quadrants, subfoveal 1.5 and 3 millimeters, and they found that a thicker inferior choroid and a thicker subfoveal choroid was associated with greater resolution with one injection, anti-VEGF injection, and also interestingly had lesser recurrence. That's something pretty interesting. Myopic tractional maculopathy is something that was coined by Penuza and Mercant again, not too long back. It's a slowly progressive degenerative disorder whose manifestations vary with A, the degree of myopia, posterior staphyloma, and vitreous degeneration, and may even culminate in a macular hole formation. So you see an example here where this very skytic macula, you can see the macula is almost as if it's ripped apart. At different levels, you see this schisis. Pathogenesis of a thickening and stiffening of the ILM prevents the retina from adapting to the posterior wall, posterior scleral staphyloma, and therefore produces both centripetal as well as tangential traction to the retina. Atrophy of the RPE and choroid may reduce the adhesion between RPE and neuroretina. Incomplete PVD produces centripetal traction as well as tangential traction. So this was their first paper which came in, and this is where they demonstrate for the first time that vitrectomy helps settle that myopic tractional maculopathy. Spade had to put a spin on it, so he said removal of adherent cortical vitreous plaques without removing the ILM can even help, as is shown in this diagram. And we'll just look at a quick case here where there's a myopic RD. Oh, and why it says cannot play media. Oh gosh. Yeah.
Wind up.
Yeah, I guess done. So I just want to, well, we've seen enough of that. Macular surgeries. Just a final talk on the endoplom Macula Buckers, which are also coming into vogue. Again, endoplom showed that fiber optic illumination is used to ensure positioning. These are the buckles which are there, and the whole idea is to unsettle that posterior wall out protrusion by buckling that central area, and you see with just a mechanical external extraocular buckle you can settle the thing. Yeah, and this is just a JAMA network video. Fortunately, this seems to be playing just to show everybody the technique. So you fix that, you put pre-placed sutures, you do the ILM peeling, and once that is done, you put this illuminator through the 27 gauge needle, affix it into the side of the plomb or the buckle, insert it, and then you remove the needle, and what stays behind is the illuminator. And you fix that temporarily with sutures there, and you insert the buckle in through those pre-placed sutures, and you illuminate the endo-illuminator and see if the positioning is right. And once that is done, then you can fix the buckle once your position is right, and this is the results after that.
This is far different from what.
Thank you.
Robert, you want to say? So, thank you. I think time is running out. Ladit, you want to finish your talk? It's okay. But then I thought from a clinical point of view, I thought I'll just give one or two messages. I think we can have a one-day program on myopia. But then from a clinical point of view, I think there are two or three things. One is lacquer cracks. Differentiating lacquer cracks from myopic CNVM, very important, because they look very similar. Patients come with sudden decrease in vision. You see a small hemorrhage in the macula. And probably fluorescein angiography is very useful at this juncture to differentiate between a choroidal neovascular membrane and a small hemorrhage due to a lacquer crack, because it's different in terms of this thing. This is number one. Yeah. Then there's one more point which I wanted to say, which I was forgotten.
Probably
Can I
OCT angiography may help now because
Girish, there are certain cases of lacquer crack where you see a CNVM coexistent. What is the experience in response to anti-VEGF therapy in these cases? Because the CNVM does subside, but somehow the vision doesn't improve. That has been my experience. I've done only 2 such patients, and the CNVM responded very well.
No, the reason why the vision doesn't improve is basically because of the hemorrhage, creating a small scar there. So that's the reason why the vision doesn't improve. But the thing is, in most patients with myopic CNVM, I think and secondly, the initiation of treatment is very important in myopic CNVM. The earlier you give the anti-VEGF, I think it works better. Actually, I had a 18-year-old girl.
basically to more of the cases quickly. So basically diabetes is a metabolic disorder of multiple etiology, and diabetic retinopathy and maculopathy basically is a manifestation of diabetes, what you are seeing. So due to breakdown of inner and outer blood-retinal barrier, leading to accumulation of extracellular fluid in Henle's layer, and that is what lead to what we call as diabetic macular edema. And it can happen in any stage of diabetic retinopathy. And this is the most frequent cause of reading vision loss in diabetic patients. So basically, when you look at a classification, like grossly for a clinical purpose, you call it as either absent or present, and when it is present, it's subclassified as a mild, moderate, severe, depending on how far exudates and edema is away from the retina. When it involves the retina, say fovea, you call it as a fovea involving DME, and other two are non-center involving, and this is a center involving basically. So to extrapolate that our ETDRS, so the first definition of ETDRS is basically center involving DME, and other two are non-center involving DME, and particularly this classification is more relevant with OCT now, because that's what now all the treatment parameters are dealing with rather than all previous multiple classifications we had. So goal for treatment here is to reduce the amount of macular edema, to reduce the leakage on FFA, and to reduce the thickening on the OCT, so that to improve or probably to stabilize the vision depending on at what stage you would like to start. And treatment options are, you have laser, which is still the first line of therapy for non-center involving DME as of now. Anti-VEGF is the first choice of center involving DME, and followed by steroids, probably especially for chronic DME or pseudophakic or eyes non-responsive to anti-VEGFs. Vitrectomy is a very specialized group of DME where probably have obvious vitreous Macula Traction, but that also is partly debatable. And obviously intensive glycemic control and control of other systemic parameters are equally important. So I just moved straight to various case scenarios. It's a 45-year-old male, has a diabetes since 3 years, complaint of loss of vision 10 days. This is a treatment. I look at that, this is a fundus picture, had a OCT showing right eye center involving DME and left eye non-center involving DME. So right eye we started with anti-VEGF, and left eye had a focal depending on where the leakage was. And with a subsequent follow-up, the left eye maintained throughout 6-9 vision, right eye had 3-4 anti-VEGF, and then you see after first injection vision did improve, but then now it's over a period of time stabilized. So we extended the follow-up and treatment. Still it is same, vision is same. So what you do in this scenario? So basically what is the current protocol available is, if you have OCT or vision, one of the criteria, if it is changing, showing some better improvement, you continue with anti-VEGF. If both are stabilized, probably you follow them after 2 to 3 months and then take a call again. Probably central involving DME is convert to non-central DME. you can consider still focal laser here. If we have a OCT shows response, but visual acuity is not responding, probably you look out for whether ischemic changes are there, do FFA. If you have vision is improving, but OCT is stable, look out for some tractional component if you have, and accordingly you want to go for a vitrectomy or change the like a drug, whether either shift to other anti-VEGF or steroid or follow it up. That's option, and then it's still this is debatable. So basically, learning point here are first choice is anti-VEGF, and for non-central DME, focal or modified grease definitely is the first option, and treat the patient, not the OCT. The second case has a 59-year-old male, DOV since 1 year, and diabetes of 15 years, vision in right eye 618, left eye 612, has Ozurdex in both eyes, had 3 injections of Avastin in both eyes, last was 4 months back, and in between had modified grid laser also for both eyes. This is like a macula showing some grid laser earlier done, and showing center involving DME in both eyes. Now, this already have all possible options detailed, but here probably again you prefer, just do not classify straight as a resistant DME. What you need to look at first, follow protocol and compliance, because if a variable compliance, you cannot blame the treatment, and probably in that scenario, again, give a chance, and we previously patient is responded better for maybe to anti-VEGF or steroid, depending, you can restart the treatment, have a meticulous follow-up and treatment protocol, and depending on continue treatment. Also another option what you have is routinely what we do is laser, classically told about beyond 500 to 3000, but in this scenario, suppose you have some leaking obvious microorganism, laser, FFA guided focal laser you still can consider in these eyes. Again, non-responsive, first thing you need to look at systemic parameters, and if sometime you control those, most of these patients will have deranged systemic metabolism, and if that is controlled, probably you do not have to treat, patient respond quite well. The next one, you have 44-year-old female, 18 years of diabetes, has a laser, both eyes for PDR, also has IVTA leading to secondary glaucoma, and then also had a trabeculectomy, and now come with a hard exudates in left eye, and you have a CME in the right eye, both eyes having a center involving DME. What to do now, basically? So because she was steroid responder, we started again with the anti-VEGFs, finished 3 anti-VEGFs, there's hardly any response. Again had one more shots, 4th one, can't do much, though left eye had some response, but basically because of cataract vision did not improve. So this is a scenario time now to take a call. Patient was using anti-glaucoma medication. So with a glaucoma specialist consent, we decided to go with Ozurdex here, and patient wanted to have treatment only in one eye and decided refuse treatment in the left eye. So what happened? This is excellent response you get here. IOP is also very much under control. So yes, but after some time, as usual, relapse, second Ozurdex, work out fine. Left eye, again he's refused the treatment. We thought we'll try similar thing in the left eye. Subsequently, he underwent cataract surgery and Ozurdex, but here now, because of this second relapse, and patient has some other constraint, he said he doesn't want Ozurdex, so we did not have choice to go back again with anti-VEGF. Razumab we used here that time, and he disagreed for other eye treatment, and this was response. It did respond to some extent and had some changes. So basically what learning take here is suspect chronic CME after 6 months, but again there's a definition is vague. Ozurdex can be used eyes with a steroid response under anti-glaucoma medication and regular follow-up. It's not like that totally contraindicated. And again, switch from Ozurdex back to anti-VEGF, probably in a chronic situation, sometime it works. So another case has a 1 week of loss of vision. Treatment 9, vision was 6.9, 6.6 here. So basically, had a proliferative retinopathy and underwent laser photocoagulation here, pan-retinal laser photocoagulation, and then he lost to follow-up, come back straight after 2 years with a sudden loss of vision since 1 month. Right eye had a vitreous hemorrhage, left eye had 624 N6 vision, didn't realize that one. So we decided, ultrasound shows attached retina, not traction on the macula, so decided to follow up right eye, no treatment given. and over a period of time, right eye improved, but what happened in the left eye, we had some membrane over it, so later we thought, let us try still with initially anti-VEGF. Did not have much response, though the macula map shows some changes, but as far as vision-wise and clinically, on OCT, you see there's not hardly any difference, and ultimately, these are the eyes probably we eventually decided, advised him to have vitrectomy. Patient did not agree, we're still waiting. Though last visit, he did show some 624 becomes 618, but this is probably, the take home here is, basically DME with vitreomacular traction may improve initially with anti-VEGF. However, watch carefully for worsening of the vitreous traction, and probably these are the good candidate for vitrectomy. So this is another case, 15 years of diabetes, loss of vision since 5 months. One eye had a PDR, other eye had NPDR, and both eyes having a center involving diabetic macular edema, was advised anti-VEGF. Now, this is erratic follow-up. Initially, he refused any treatment. So ultimately managed to come back. I've convinced him, came after 7 weeks for first injection, had anti-VEGF there. 2 months, again next follow-up straight after 2 months, again relapse. In between we did not know what happened. And because of his irregular follow-up, he can't come. We said, okay, let us try Ozurdex. Patient chose glasses. He said he didn't want any injection treatment again. Came again after straight 5 months. You have a sensory detachment here. Okay. So here you cannot blame the treatment here. Look at the follow-up, how it is going on. So we advise Ozurdex. He has taken Ozurdex in only left eye, and also now he has a PDR in the left eye, so he may decided to have PRP in the other eye, left eye alone. 6 weeks later, again the same problem. Now he wanted, okay, I will have Ozurdex in the right eye. So absolutely erratic follow-up and erratic treatment. We did not have control on this scenario, and again back and forth, and in between systemic status was wrong, and he had a congestive heart failure. He had other systemic issues. So when you look at this now, ultimately he agreed, and here both eyes we gave injection, did show some response, though vision did not improve over progressively. As the vision is going down, changes are not, but here some response he showed. We thought, okay, we are catching him up. Subsequently he says, no more treatment, finished. I don't want anything else. So basically what, again, it's a typically real world situation, what makes the management challenging. And financial constraint, logistic issues have impact on treatment, and obviously probably poor vision scenario. And sudden drop in a range, particularly certain cases, obviously definitely you need to rule out optic nerve perfusion or pallor. Ask your neuro-ophthalmologist, also have to look at. And when you look at these systemic scenarios, life is first and then the eye. And this is probably last case I am talking about. This is patient, again one-eyed, had a diabetic from 25 years. This is when he presented us 618 vision, huge towering macula here with a traction. Vision was 618 and 6. I gave option vitrectomy. I said that's the best option in given scenario. Let us have. He said no. He said this is only I do not want any treatment. I tried to convince. Fine. Continue follow-up. He comes after 2 years. Vision is exactly same. Though OCT shows definitely now deranged, our situation has worsened. I gave, knowing at my past experience, vision is maintained. After 2 years, I said, okay, observation versus vitrectomy, what you should have. But I was more on the vitrectomy side. He says no. Again, next year, same scenario, same thing, but vision now is 1 line down. Look at this over the next 5-year follow-up. Just 1 line drop. Macula looks more or less same. He's still holding on. He doesn't want any treatment. So basically, what we learn here is traction, progression is extremely slow, this type of eyes, particularly if do not have any active disease, and intervening in one eye only when documented worsening of clinical feature, or because surgical intervention sometimes can worsen the situation as well. So probably patient is not clean, don't force him, but have a very close follow-up. Just to sum up again, few things, what are the markers for the function? If you are disorganized retinal inner layers, that is what we call as drill now, if it is more than 50%, in a central 1 millimeter, that is a poor sign of progression, prognosis. Extra limiting membrane disruption and loss of ellipsoid zone, again it's a bad prognostic sign. If you have loss of parallelism, again it's a bad prognostic sign. Central macular thickness somehow, or you have a retinal processes, or you have intraretinal cysts, does not have much prognostic value, though we feel that these processes may have probably marginally better prognostic sign. How your hard exudates, large hyperreflective dots, and shadowing probably can be, it's a good prognostic sign. Probably it indicates macula is better perfused, ischemia is less. But as against the hyperreflective small tiny dots may indicate inflammatory reaction, and this is considered as a bad prognostic sign. Yesterday we were discussing again neurosensory detachment. Though few reports are there, it's a good prognostic sign as far as functional outcome is concerned, but long term probably eventually these eyes also vision significantly goes down. And if you have response like a periretinal membrane or wrinkling, probably that is generally like a not, I say, satisfactory or less responsive to your medical management, and these are the cases probably more for vitrectomy. And again, if you have deep clarial plexus and if you have a loss of capillaries here, it's again a bad prognostic sign. So to conclude, the message for like a management of DME has come a long way since ETDRS 1985. Laser still is a first-line therapy for non-center involving DME. Anti-VEGF agents, definitely the first choice for center involving diabetic macular edema, followed by steroids, particularly in chronic diabetic macular edema and eyes non-responsive to anti-VEGFs, and vitrectomy probably reserved for where you have Macula Traction. And intensive glycemic control and lipid control definitely has a significant role in management this size. So thank you very much for patient hearing.
I think we'll go ahead with the next talk because we have 2 more talks left. Macula and pachychoroid by Dr. Giridhar. And there's an announcement at the conclusion of the session. There is a 1-minute silent homage for the Jawans who lost their lives in Jammu and Kashmir. So would request everybody to stay back for that.
Thank you all, and we just move to the next talk. We are running out of time. I would be in the next 8 to 10 minutes give a broad overview of what pachychoroid is. I'm not going much into the management because the idea is to make everyone understand, to recognize this clinical entity in our practice. So this is a new concept, a novel concept which was described in 2013, and basically the word pachy means thick in Greek. But over the years, generally, the definition of pachychoroid has changed. Can I have the pointer, Pramod? Yeah, over the years, the definition of pachychoroid has changed from just increase in the choroidal thickness. You can see here, this particular eye. These are different pictures from different patients, just to describe what exactly is a pachychoroid. So basically, we have an increased thickness of the choroid here. The choroid thickness is more than normal, and you can see there's an enlargement of the outer choroidal vessels. But most importantly today, apart from the thickness of the choroid, which probably is not that important, are the morphological changes that we see along with the increase in the thickness, or probably a slightly abnormally thick choroid. So other changes that we see is the enlargement of the outer choroidal vessel, what we call as a hallux layer, which is very beautifully seen in this particular slide and this particular side. And more importantly is the irregularity in the retinal pigment epithelium. So what actually happens, or what has hypothesized, is that the increase in the outer choroidal thickness compresses the inner choroid or the choriocapillaries. This results in some sort of an ischemia and therefore damages the overlying retinal pigment epithelium and the Bruch's membrane. And you can see here there's an irregularity of the retinal pigment epithelium. The retina as such, the scan looks near normal, but these are subtle changes that we need to address to define a patient with a pachychoroid disease. Therefore, when you see an OCT, you need to see all the sections of the OCT, because otherwise you may miss very early pachychoroid changes, which are probably asymptomatic in the early stage. Today, the pachychoroid disease spectrum involves a galaxy of diseases, right from the pachychoroid pigment epitheliopathy to neovasculopathy to what we now is described as aneurysmal dilatation, that is polypoidal choroidal vasculopathy, focal choroidal excavation, peripapillary pachychoroid syndrome, and central serous chorioretinopathy.
So what is pachychoroid pigment epitheliopathy? This again was described by Bailey Freud way back in 2013-14. These are actually subtle changes in the macula. What he noticed patients with slight RP alteration in the macula with normal visual acuity. And these probably in our practice we generally call it as RP atrophy or early macula. And they usually many of these patients are misdiagnosed as macular degeneration or macular dystrophy, especially if they are bilateral changes. So just to describe what exactly is pachychoroidopathy, I'll just show you one of our cases. This is a patient who had a serous macular detachment in the right eye, but when you see the left eye, has got typical pachychoroid changes. These are basically, you can see these RP alterations, which are now described as pachydrusen by Rick Spade. That is, pachydrusen is basically drusenoid changes that we see in patients with pachychoroid disease. And if you look at the OCT, as I told you, you need to look at all the sections of the OCT, and if you see there is an increase in the thickness of the choroid, you can see these slightly enlarged vessels here, and more importantly in the infrared pictures you can see these focal areas of increased autofluorescence, which are very diagnostic of the pachychoroid epitheliopathy, and also you see these focal changes in the retinal pigment epithelium, which is again a very, very important feature in early pachychoroid pigment epitheliopathy, which is actually asymptomatic. And therefore, to see this particular thing in a more enlarged image, you can see the increase in the thickness of the choroid, you can see the enlargement of the outer choroid, you can see these small irregular changes in the retinal pigment epithelium and the overlying ellipsoid layer. These are very critical changes to describe pachychoroid pigment epitheliopathy. If you do an autofluorescence, you see these focal areas of increased autofluorescence, which again is a very diagnostic feature of pachychoroid pigment epitheliopathy. Is this the forme fruste of the disease, and whether these sort of eyes progress to neovasculopathy is a very difficult question to answer, but definitely it probably is in some spectrum of cases. This is the first set of cases of pachychoroid neovasculopathy, which was again described by Bailey Freud a couple of years ago. These are just 3 cases, and I'll just show you one of our patients to describe what exactly is pachychoroid neovasculopathy. This is the fellow eye of the same patient. You can see here the patient has got a serous macular detachment. It looks like central serous chorioretinopathy, but if you see here, as I told you, you need to see this particular irregularity of the retinal pigment epithelium and the elevation here. This is very diagnostic to tell you that this is not a classic case of central serous chorioretinopathy, but there is not much more in this particular patient other than a CSCR. So if you see the multiple sections, you can see this elevation in all the sections. So in this particular area, there is probably a neovascular network, and when you do the ICG angiography, you can see this network of vessels here. You can see the large network of vessels here, with early aneurysmal dilatation, probably going into polypoidal disease, but more importantly, a large network of vessels corresponding to the area which is actually corresponding to the area of the irregular, very difficult. I think I'll have to go forward. Okay. Corresponding to the area of the neovascular network. You can see here, you can see as it passes, you can see here the irregularity of the retinal pigment epithelium corresponding to the area of the neovascular network. Therefore, this is a case of pachychoroid neovasculopathy. Therefore, using multimodal imaging, you have the serous macular detachment, you have what they call the double layered sign, you have the neovascular network, and you have this elevation corresponding to the aneurysmal dilatation of the vessels at the end of the network of vessels. Therefore, this is something which we recently reported in the Indian Journal of Ophthalmology, just to show you the progression from a pachychoroid epitheliopathy to a pachychoroid neovasculopathy, and finally a polypoidal or an aneurysmal dilatation in one eye of a patient over a period of 1.5 years. So you can see here earlier, initially you can see the irregularity, there is no macular detachment, there is minimal serous macular detachment. At that time when we did the ICG angiography, there was just a neovascular network, and subsequently you can see this elevation at the end of these areas. These are the network of polypoidal vessels, aneurysmal dilatation. Therefore, it is possible that pachychoroid epitheliopathy is a forme fruste of the disease and slowly progresses to neovasculopathy and later an aneurysmal dilatation resulting in polypoidal disease. This again is another patient. You can see here a dry macula. You can see a little liquid. At that time, there is just a type 1 neovascular membrane and subsequently a polypoidal network, again showing you the natural progression of the disease. We also recently reported the lateral elongation of the irregular retinal epithelium. This again is a very important sign. When you see this particular sign, probably you are having a harbinger, and if you do an octa, you may see a neovascular membrane even at this stage, but then this slowly increases in length, and subsequently you see the fluid coming in here. That is an active disease. Therefore, you have the length is only 2,200. It has increased significantly over a period of time before it becomes symptomatic. Therefore, now we know that once we have a patient with this sort of a disease, if you do an octa, it is more sensitive than doing an ICG angiography. This is a particular case to show you where you have a dry macula, you have an irregularity of the retinal pigment epithelium, suggestive of a epitheliopathy, but probably there is a neovascular network. And if you see the, or do the octa, you can see the nascent pachychoroid neovasculopathy in these sort of cases, where these patients have near normal visual acuity. This patient has been followed up for 1 year. There is no active disease even now, but then there is a silent neovascular network. This again is another patient from our series, just to show you the long-term follow-up every 3 to 6 months, repeating the multimodal imaging, showing you a silent neovascular network in this sort of a situation. This again is another case, just to show you here the irregularity of the network, and corresponding to that, you see a neovascular network suggestive of a silent nascent pachychoroid neovasculopathy. Therefore, the other disease is focal choroidal excavation. A lot of reports recently, we cannot go into the details now, but then focal choroidal excavation can be associated with pachyvessels and increased in thickness. Therefore, this again probably is a variant of pachychoroid disease, which has now been described in literature, but again is a most important differential diagnosis, and we need to look for these small areas of choroidal excavation in the absence of any scleral ectasia or staphyloma. That's very, very important. You can see multiple cases here. Therefore, in conclusion, what I would like to say is that this is a primary choroidal abnormality. We are still in the learning process. Whether there's a genetic predisposition, we do not know. Do we need to redefine central serous chorioretinopathy? Because that's a separate topic. I have not gone into that at all. But then we need to remember that patients coming with elderly patients who are coming with CSCR are probably harbingers of neovascular disease, and they need a more careful examination, including an octa, and also, if possible, an ICG angiography. Thank you all. I hope you have been able to.
Thank you, Dr. Giridhar. Because Dr. Lalit Verma's topic is also interrelated, any questions we take after that? So, macula and central serous chorioretinopathy by Dr. Lalit Verma.
You see, OCT revolutionized the management of a lot of retinal diseases, but now the focus, even in OCT, is shifting to choroid, and that's what Dr. Girdhar touched upon, that now we are looking at the choroid for solution for a lot of these diseases. Pachychoroid has already been covered, so I'll exclude, but only thing is it's a continuum. So patients may have, in one eye evidence of, say, CSR, in another eye maybe APCV. So associations have been established, and we are continuing with the advent of swept source OCT and EDI. We are continuing to learn. In fact, I personally believe this is a spectrum which is, there are a lot of overlap between these. And Pachy has already been discussed. We'll just swip these slides. And all these three things have to be there. Increased thickness, dilatation of the halides layer, and compression of the satellar and the choriocapillaries. So this right side is very, very typical of Pachy disease. While considered primarily on CSR, we will not go into the history of definition, but it's a idiopathic young male. Diagnosis is generally not difficult, but these three diseases are generally associated clinically, like type A personality and hypercortisolemia, endogenous cortisol or exogenous, and hypertension. And only thing to be stressed to everybody is that inferior margin should be always seen, and BCVA generally improves with a low plus glasses. Investigations generally may or may not be required if you are doing only first time management, but fluorescein angiography, ICG and OCT needs to be done if you are contemplating some treatment. This is how an angiogram may look like in a patient. Focus so that this is the leak which is very, very active. Rest are showing pigment epithelial detachments only. And this is the OCT classically seen in these patients. This was classical CSR, but you may have variants of CSR. like atypical CSR, which is associated with RPED, and hence I said there could be a lot of overlap in this spectrum. And based on leakage, you could have single leak, ink blot, smokestack, or inverse smokestack, or multiple leaks also. Then based on size, like giant CSR also has been described. And based on chronicity, we have acute CSR or chronic CSR. So these variants could be encountered in clinical practice. What is relevant is I'll show you a couple of cases that from the management point of view, if patient comes for the first time, the management is generally masterly inactivity, give some placebo, tear drops or something, but do some baseline imaging and rule out certain things like steroid intake. This may be possible in skin creams or some inhalers or some unknown homeopathic medications. This is one patient who has had this symptomatic patient who has this ink blot leak and spontaneous resolution just with no treatment at all. Problem comes in recurrent or chronic CSR. At this time, we repeat the angiography, try to locate the leak, and if it is the safe area without damaging the central part, gentle laser is the treatment of choice. This is one such example where we have both in the right eye, left eye, which was lasered, and you see the OCT resolution before treatment and after treatment with very gentle laser. Couple of spots are required. Power has to be kept low, spot has to be maximum possible spot size. Here the leakage was miles away from the center part and it resolved very, very nicely. Another patient, very good response to conventional laser. This was a patient on kidney disease, right eye, left eye both, and had bilateral giant CSR. You see both right eye as well as left eye showing multiple leakages, and I still did focal laser on him, and this right eye showed minimal improvement from finger counting to finger count 3 meters, but in the left eye he improved dramatically with conventional laser over the course of 10 weeks from 60 to 6.9, although the amount of laser required was quite a big. And this is the OCT of the same patient showing pre and post, again of the left eye pre and post. This was an anesthetist whose basic complaint was who could not insert the endotracheal tube. You see this patient had undergone, he was on anti-tubular treatment also. You see ATT is overused for CSR. I personally do not believe that there is any role of ATT as a causative agent in CSR, even if it is a multiple CSR. So this patient, although leak was very, very close to a juxtafoveal leak, I still dared to do a very gentle couple of spots of laser. This marked resolution clinically, fibrin went down and the leakage also ultimately went down and OCT also improved. This was, other eye also he had similar picture, we did a small focal laser on him. This was one of the recent, lot of fibrin deposition and he was diagnosed something else, in fact retinitis elsewhere. But you see the clinical picture, angiography, typical of CSR. We did ICG also just to rule out IPCV in such. So this patient again responded to this gentle laser photocoagulation. The problem, real problem challenge comes once a patient of recurrent or a chronic CSR has the leak in a central part, and that is the area where a lot of treatment options, medical treatment people do. But believe me, the role of them is not established. Therefore, I put a very big question mark. You may have success rate, patient may respond, but saying that patient will respond is very difficult. So I have, tried even rifampicin or eplerenone, but success rate is say around 20-30%, and you can't predict this. So PDT has came in a very big way. Rifampicin and all these drugs work rifampicin does not work because of anti-tuberculosis action, but primarily because it increases the metabolism of endogenous steroids, so that level goes down. This is one such patient where this was done photographs elsewhere. So I did put this patient on 3 months for rifampicin, and patient did improve, but again came back. So as far as VEGF, CSR, pure CSR, unless it's a part of neovasculopathy as a variant of Pecky's spectrum, as a pure CSR does not require Avastin or Lucentis for management. Although there have been series which have shown, but not conclusive. There are other series also which have shown no benefit of anti-VEGF agent on CSR. However, PDT, specifically low fluence PDT, in my hands works the best in these patients of chronic CSR with central leak. This is one patient who had multiple injections of Avastin, so and had recurrence every time. So this patient we did low fluence PDT and responded dramatically. This is post PDT, the upper photograph. This is another patient who had 9 injections of Lucentis and had central leak. This was a variant of Pecky choroid disease, which Giri was telling. And this post PDT, this patient did marvelously well and still in remission. So we have had long series of this disease where low fluence PDT has been used successfully in chronic CSR with central leakage. Just to summarize, first episode, masterly inactivity, rule out steroids by all possible routes. Chronic CSR, laserable, do a gentle laser. If not in safe area, low PDT or micropulse. Micropulse, I do not have any experience, but literature says it works pretty well. In my hand, low fluence PDT is the treatment of choice for chronic CSR with central leak. Thank you very much for your kind attention.
Thank you. Thank you, Lalit, for really summarizing the whole thing well. Please observe 1 minute silence in memory of the Jawans.
Yeah, this slide I just sent from sitting here to all the halls. Slide लगा दो. I'll request all the chairpersons, wherever you're going, please, at the end of session, 1 minute silence in the memory of these martyred soldiers. Thank you.
There is a spot registration counter for the VRSI meeting 2019 in the basement at a attractive charge of 6,000 rupees for the complete registration. If anybody is interested, we would request you to kindly take them.